another notorious for drug-to-drug, check for your omeprazole and also your cimetidine, but you don't use cimetidine. Usually rifampin talaga, no? So please take note, it's an MDR1 inducer, no? So there's high expression, high metabolism, so your patient, the other drug B might not, the patient might not respond, or you don't see the therapeutic effect of drug B because of the inducing effect of your rifampin. Okay? So that's it. So MRP3 is in the liver, so specifically your glucuronide conjugates. MRP4 is in, enhances your renal concentration, no? And again, another more examples, no? More examples. RP1 and 2 for glutathione glucuronide. 3 is lower, has a lower transport affinity for glutathione. MRP4 is for your negatively charged molecules. MRP5 for anti-HIV drugs. BCRP, breast cancer resistance proteins. So these are the different anti-cancer drugs, no, that makes use of this transporter. Okay, let's see 3 different transporters in important organs. First, your hepatic transporter. Example again is your statin, no, HMG-CoA reductase inhibitor. Uptake transporter is OATP1B1. Efflux is MRP2. Again, very important for concentration or uptake and for excretion. So this is an important drug-to-drug interaction. Your gemfibrocil. Gemfibrocil is also a cholesterol-lowering agent, but the action is not via HMG-CoA, but it's via your peroxisome proliferator activated receptor, PPAR. If you give statin plus gemfibrocil, no, it enhances the toxicity of your statin because it inhibits the uptake of the hydroxy forms of your statins into the hepatocytes. So you increase the levels of your drug into the circulation, not into the liver. So statin plus gemfibrocil, a big no-no. And it doesn't make sense actually as also, no? You have your statin is already a good anti-cholesterol drug, no? So that's one, okay? That's one. Patient definitely will have muscle myopathy or myopathy, no? ARBs, what are your ARBs? Antihypertensive drug, right? Remember your angiotensin 1 to angiotensin 2 by your ACE, right? And your angiotensin 2 attaches to your angiotensin receptor, then you have your increase in your blood pressure. So things that you could do for hypertension, you inhibit the ACE or you inhibit the transporter parts. So telmisartan is taken up by OATP1B3, no? And MRP2 plays a role for excretion of the drug. So that's hepatic. Let's go to renal transporters. In the renal transporters, you have cation transport and you have anion transport. Okay? So the role of the cation transport is to eliminate organic cations or even eliminate toxins and your xenobiotics. So again, as was mentioned in the video, no, your transporter must traverse across your basolateral and the luminal side, no? Basolateral membrane facing the blood side, no, circulation here. The luminal is facing your tubular lumen. This is kidneys, no? So there are 2 transporters in the proximal tubule. SLC family 22. So you have OCT2, organic cation transporter 2, and organic cation transporter 3, no? SLC22A2 and 22A3. And both of them transports cations via following your electrochemical gradients. Now there are 2 modes. There may be reuptake mode and secretory mode of your OCT. So the reuptake mode, the transporters function as sodium co-transporters, no? Relying on the inwardly driven sodium gradient created by your sodium-potassium ATPase. To move, you see here, to move your carnitine from the tubular lumen to your cell. So that's the reuptake mode. The secretory mode is that they function as protein organic cation exchangers. So from the tubular lumen to the interior in exchange for organic cations. You see your OC or hydrogen ions. Okay? So please take note with the difference between the two modes. And of course, examples. I'll leave that to you, okay? I'll give this to you, by the way. So, OCT, and then next is anion transport. Everything here is actually good, man. No? So, OAT, also for removal of your xenobiotics, specifically for your weakly acidic drugs and other toxins. So, the primary transporters for OAT are your OAT1, A6, OAT3, A8. What do you see here? In organic anion transport, they are transport against, no, unlike your OCT, it's against electrochemical gradients, and it exchanges what? Alpha ketoglutarate. No? Where do you find alpha ketoglutarate? Where do you find alpha ketoglutarate? In Krebs cycle, right? No, so you need that, no, because it's also very much needed in organic anion transport. Alpha ketoglutarate moves down its concentration gradient, and the OAT transporter moves against its concentration gradient. Okay, so yeah, that's it. So these are some examples of your OAT transporters. Now, in the brain, what is the most important transporter in the brain? It's your gamma-aminobutyric acid. It's GAT1. No? It's the most important. But you also have GAT3, GAT2, and even your BGT1. So for catecholamines, what are your catecholamines? Epinephrine, norepinephrine. You also have NET, the norepinephrine transporter, SLC6A2. You have your dopamines, SLC6A3. Serotonins, I mentioned to you, SLC6A4. Very important for SSRI drugs. And lastly, your blood-brain barrier. No? So, of course, brain is very important. So the blood-brain barrier protects the brain from many toxins, bacteria, and xenobiotics. So what are the parts of the BBB? There's a physical and there's a metabolic barrier. So physical part is taken care of by the endothelial cells, which have tight junctions in it, that limits flow, paracellular flow with very low rates of your vesicular transport. So it can only accommodate oxygen, carbon dioxide. No? Others cannot diffuse readily. Metabolic barrier, also, one example here is, how do you treat Parkinson's disease?
Low dopa.
Yeah, so the problem with Parkinson's disease, you have low dopamine, right? So, common sense, you have to give dopamine. What's the problem with dopamine?
Yun nga pa.
Can cross the blood-brain barrier. But the substrate, levodopa can cross. That's why we give levodopa, and in the brain is converted to dopamine. But another thing, another challenge for giving levodopa is what? Decarboxylation by your dopa decarboxylase. No? So that is why when you give your levodopa, you have to give it together with a decarboxylase inhibitor. So it's a combination drug. Just to make sure your levodopa prior to entering your brain is not metabolized. Okay, so yeah, that's it. So these are some of the transporters. Okay, so any question? This is also the same. This is the same example. No? Your statin plus gemfibrocil. Make sure you don't do that